Welcome to the Clearly Beneficial podcast, the show where we rip off the Band-Aid and explore the future of healthcare, benefits, and the people driving innovation in the industry. This episode is brought to you by HealthNext, the company leading the way in helping employers build enduring cultures of health and well-being, reducing medical cost trends, and increasing organizational performance. To learn more how they can help you, visit healthnext.com.
Well, hello, everybody. Happy Monday. And this is a Monday that we're recording. It was a very wet Sunday night here in Northern California, but I'm really excited to welcome Larry Thompson to the Clearly Beneficial podcast. Larry and I have known each other, it seems off and on for 10, 15 years. And I consider him, one of the OGs of the industry. His background is broad in the healthcare space, particularly in the arena of self-funding. He's done a number of things over the years, in my mind, to be super innovative in the areas of funding and other areas. And we're going to cover a lot of that in the podcast today. So welcome, Larry.
Thank you for having me, Vinny. Good to see you.
Great to see you. And so maybe for the benefit of the audience, maybe give your kind of 30-second to 60-second, who you are, where you came from, how you got into this business, et cetera, et cetera.
Okay, it's going to be hard to compress 46 years into 30 seconds, but I'll give it a whirl. I was born and raised in Jamaica. I swam all the way to California. Here I am. No, I'm joking. I was born and raised in Jamaica, but I went to university here, undergraduate, graduate. Did not mean to go into the insurance industry, as so many people, I'm sure,
who does
have the same story. And ended up starting my career with Aetna Life Casualty. Spent 4 years with them and then left them and finished my MBA and then went to work for Plan Services, which was quickly bought by Dun & Bradstreet and became the largest TPA, I think, in history thus far. And I became executive vice president, spent 8 years there. Left that and decided that I was going to become a general agent and opened my general agency here in California, and found that people really didn't want me to be a general agent. They wanted me to go back to being a TPA. So I ended up opening my own TPA and ran that for 16 years and sold it and thought I was going to get out of the business. That did not work.
Well, it's kind of like the mafia, right? You get out and then they pull you back in.
Yeah, it was like they had the dirt on me and it was just constant. And actually it was my CPA who came to me and said in 2002, he said, Larry, listen, you just can't keep getting checks from these people for doing consulting for them and putting them in your personal bank account. You need to form a company. And so hence Benefit Systems was formed in 2002. And, I've spent the last 20 plus years doing all kinds of interesting things, all driven from the consulting side, but doing what I call residencies with my clients. So when I first started out, I was consulting with a BPO technology company in Texas that was on the NASDAQ exchange. And they asked me to come in and help them in trying to groom the company for sale. I gave them a strategic plan and the board liked it so much. They said, look, would you join us as COO, help us to get it ready and going? So I took 3.5 years, went to Texas and did exactly that. And we ended up selling it. Great experience for me because I filled a gap I had where I really didn't know the BPO and technology side as well as I knew, the finance and the sales and brokerage side. So that was great experience. And of course, I also learned a lot about public companies and all the regulations around.
Right.
And then got recruited from there to do some consulting for a holding company in New York, upstate New York, which ended up owning 2 blue companies. So that became my blue experience because they asked me to join them as the chief commercial officer for 2 blues in in Buffalo and Albany. And so that was quite an experience, quite enjoyable. Big weather change from California.
Yep. Yep.
Um, and then when my contract was up, my beautiful wife said, I need to get back to California. So we came back
As
here,
one does.
as one does. She's a California born and raised. She didn't like the snow. So
Yeah.
came back here and then, just continued to do consulting. Um, I actually had a TPA I tried to buy when I was with the Blues in Syracuse, New York, and they didn't want anything to do with the Blues. And when I left the Blues, their owner and CEO contacted me and said, Hey, would you come here and help me to groom the company for sale? I'm getting up in years. I'd like to go. At the time, it was the largest independent TPA in the country. So again, I took off and I stayed in California, but did a lot of commuting.
Yeah.
And we took that company and ended up selling it to United at the time for the highest multiple a TPA had ever gone for, which was fun. Had a lot of fun doing that. It was a great, great organization. Um, and then left that and, came back and just again working for a variety of different organizations, doing a lot of different things. And that's when, of course, kind of in between those two things, when I was working for that TPA and doing a little consulting, that's when I started working with Duncan and all the folks at Dignity when I met you.
Yep.
And
Right.
yep. And so we continued that D2E program for 12 plus years, working with Tammy and the folks over there, which was a great success.
Yep.
And funnily enough, we're still working with them. So it's kind of fun.
Well, I mean, that thing was, I think, again, innovative. Your background has always been very interesting to me because you literally came into the business from the self-funding TPA side. So you knew what the building blocks of the industry were. It's like you knew the behind the scenes secrets of how a health plan functions. And you use that knowledge to innovate in various ways, which you're still doing, I think, today. And so
Yes.
a lot of people don't come into the industry with that. I didn't come into the industry with any of that knowledge, right? I came into the industry as a broker, selling small group, fully insured, and I would say most of my career was in the fully insured environment with some self-funding and level funding. And the more you're in it, the more you learn, right?
Right.
You definitely came in almost the yin to my yang in a lot of ways, because you came in knowing. I always talk about fully insured is you buy the Lamborghini, and self-insured you build the Lamborghini. And we came at it from two opposite places. Wouldn't you say that?
Yeah, yes and no. I mean, my original start with Aetna was all fully insured, large
Okay.
group, small group. Dun and Bradstreet, we were the largest MET TPA in the world. So I had 16 fully insured carriers that were my responsibility. And all we did was small group. We were writing 4 to 5,000 cases a month in small groups. So I had a lot of experience there.
Yeah.
Um, and actually didn't really taste self-insurance till we started to acquire other TPAs
Mm.
because our MET business was growing so fast. And I was part of that acquisition team. And as we started to buy the TPAs, a lot of them were very biased towards self-funding. Most of their business was self-funding and less of it was MET. And I had no choice. I had to learn that business relatively fast. Now, I'd known the reinsurance side because we had to do a lot of that with the MET
Yeah.
stuff.
Yeah.
So it's kind of weird. I kind of had experience on both sides, and it gives you perspective. I think you're right. There is a lot there, and of course, self-funding is much more structurally innovative in that there's more flexibility
Right.
and you can do things differently. And so that's kind of what attracted me into the TPA side because I felt like you could innovate, and we did a lot of that when I owned my own TPA, and we're still
Yeah.
doing it today.
Yeah, no, I mean, when you came to the Sacramento market with the Dignity program, the direct to employer market program that you were rolling out, I believe in, you had a Bakersfield, Ventura up here, and maybe a few other locations. I mean, I thought that was really um, a really smart way of approaching self-funding for employers. I think, and where I want to I want to later in the episode, I want to talk more about what you're doing today because it's really interesting. But what I want to kind of segue into is sort of the current, how do we get to where we are today? I mean, we're at a point in the industry in health insurance where, and I'm not even going to go into the ACA plans and all the headaches going on with subsidies or not subsidies and all those trials and tribulations. But I feel like, and I've said this for a couple of years, that the group market, the employer market, particularly the mid market, and I'm defining mid market, that kind of 500 to 5,000 sized employer, um, is I feel like they're in crisis in a lot of ways. We're hitting a point where the premium, the effective premium to cover an employee is pushing $1,000 a month. The family is 3 to 4 thousand a month. So we're talking real real dollars. And I reflected back on looking at when I started in the business in 2003, what it costed then to insure an employee, which was probably around $150, and $450 to insure the family. And now we're almost adding a zero to all that. And so I kind of want to discuss with you how we get here. How did we get to where we are? I mean, everybody wants to blame the evil insurance companies, but I think there's a lot of blame to go around, don't you think?
There absolutely is. And one of my heroes in my traveling journey has been a guy named Uwe Reinhardt. And I don't know if you know who he is, but he is famous for having published an article in 2003 titled "It's the Prices, Stupid." And he was really a famous economist, and he died in 2017. But what was interesting is that after he died, Harvard Chan School of Public Health and LSE, London School of Economics, where I went, published in March of 2018 a definitive article in JAMA that basically debunked all of the thoughts that people have around why healthcare in the US is as expensive as it is. And I
Yeah.
would say to all of your readers, go find it. It's a short read and take a look because it really focuses on what I've said now for at least 30 years, which is the unit cost of healthcare in the United States is just too high, and there is no explaining it. There's no excuses for it. Personally, I've lived under four different healthcare countries, if you will: Jamaica, Canada, the UK, and the United States. So, I mean, I can talk from personal experience, but I can also talk from working in those countries. If you look at the OECD nations, there's seven, the big ones, right? The Europeans, the Canadians, Japan, etc. That's the benchmark that we compare ourselves to. If you look at any of those cost factors, you're going to find that we just charge too much. I mean, I'll give you a living example. My niece is a fully certified orthopedic surgeon in the national healthcare system in England. She has busted her tail in just like anyone in the United States would, and is now a specialist. Do you know how much they pay her?
125,000 a year.
That would be a blessing. Try 97,000
Wow.
and compare that to what was just published, which is what is the average orthopedic surgeon making in the United States of America?
$350,000.
$478,000. Now, take that across the board on anything you want to take the measures against, and you will find, compared to all these other nations, that's our problem. Our problem is that we are spending too much money on healthcare. And let me debunk a few things. They, one of the things that people say all the time is, well, we overutilize healthcare. This study showed that we're about average. The time inpatient, the amount of physicians, etc. People argue and say we have too many specialists. Debunk that. If you go and look, actually, compared to those OECD, we're about the same. So what I guess I've taken away from this is, do we have other problems in the healthcare industry besides cost? Absolutely. But where I think Reinhardt was a brilliant person in 2003 to say it's the price, everything starts with that. How can we exist as a society where a family of four pays between $27,000 and $30,000 a year for healthcare, according to the KFF
before they
study just
before they even use any of it.
Exactly. And we all know what's happened there, right? Because
Right.
plan designs, the way they are today, we're not talking about $100 deductible plans that you were selling when you entered
Yeah.
the list, right?
100% hospitalization plans, $10 copay plans.
Or God forbid, when I entered the industry in 77 in Texas, where we were selling 100% benefit plans, period. There
Yeah.
were no deductibles. There was nothing. And an employee cost was about $25, $30 a month. So
Well,
everything ties
we're
back to that.
let me just try to chime in real quick, and then I'll let that let you keep going. But I always blame the fact that, if you remember the mid 90s, right? I mean, I came into the insurance business in 2003. But in the mid 90s, when I was, in different industry, doing different things, the big buzzwords were re-engineering the corporation. Everybody was
Right.
re-engineering. They were becoming more lean in their operations. They were, high quality, lean manufacturing, all lean processes, all the things. I feel like that whole conversation bypassed the healthcare industry
It
on
did.
every single level, with the exception of probably pharma manufacturer. And in the day-to-day operation of hospitals, there's nothing lean about it. And because of the inertia that has gone on for the past 30 years, you cannot stop and get in front of that train and stop it. They're building a brand new, every morning I talk about perspective. Every morning I take the dog for a walk around the cemetery here, East Lawn Cemetery. And right in my eyesight every morning is the new hospital tower they're building at UC Davis. Okay. I remember going to an event a couple of years ago, the Business Journal Healthcare Breakfast, where the guy who was the interim CEO of UC Davis Medical Center got up there and said, "Yeah, the price of that building when it's all in is $30 million a bed, a bed." You know, everybody's like was shocked at that number, and he went on to justify it in some way. But that's where we're at. Is that hospitals, in a sense, I always joke that Kaiser played with monopoly money. Hospitals, in a sense, they play with monopoly money. Is that resonating at all?
I refer to them as an oligopoly. And if you look, their practices are rinse and repeat. And so I tease people and say, you want to have some fun? Go take a 10-year longitudinal look at the CEOs that have moved around from hospital system to hospital system. Go and find an outsider that has been brought in to truly bring in innovation and change.
Right.
It doesn't happen. And so the problem is, what's the definition of insanity, right? Doing the same thing over and over again and expecting a different result. And the other thing I think we have to recognize is that managed care was a boondoggle. It was an absolute failure. Pay for performance, value-based care, all of it. We statistically now know that it does not have the effect that we were told it was going to have.
But it's
And
coming roaring back now. I mean, I feel like, people are back on that again.
Yeah. No, you're correct. And so I think part of the challenge is that people are sucked into that thinking, oh, this is going to be better. The same way we were told Obamacare was going to decrease costs. Um, no, it never could have decreased costs, and it's done exactly what it was designed to do, which is to drive up costs. So
Yeah.
I don't want to spend too much time on it, but my personal opinion is after all this time and everything I've seen, that at some point we have to get a handle on the unit cost of healthcare. Now, once we do that, then we start to solve other problems. Because is there an access problem for healthcare in the US? Absolutely. Even with Obamacare, we have 28 million people underinsured or uninsured. And oh, by the way, that number really hasn't budged in the 10 plus years of Obamacare.
Yeah.
Number two, quality of care. Quality of care has to be addressed, but again, you got to get the costs in line first, and then we can address those things. So I think it's a trickle down effect, and we've got to get there. And so, you know,
Well, I kind of feel that, back to the aforementioned, hospital execs. I mean, what I jokingly say as well is that, name me one hospital exec that will stand up there and they'll talk about their quality ratings and the new construction and the new Gamma Knife, but, nobody's talking about, well, I'm going to lower costs this year. Not even lower costs, keep costs flat. And no one's even doing that. So that's kind of one interesting thing. The other bits is that I feel like, to your point, the ACA plans, if you, and I noticed this very early on, the ACA plans we do a renewal for a client and bronze plan, a silver plan, whatever it is, and the premium might go up, let's call it 10%, but then the deductible would also go up 10%, and the out-of-pocket max would go up 10%. So the real implied increase wasn't 10%.
no,
If you had kept the deductible and the out-of-pocket max the same, those plans would have gone up 15%.
exactly.
So, and it's been this death spiral, ever since. And so,
Yeah, and you see the charts I see, all these wonderful charts that get put out there, the inflation of wages, this, and then healthcare up at the top. And all of those healthcare charts that you show, which are way above and are making a good point, they are about premium. They're not talking about overall costs.
yeah,
And so when we look at the cost shifting that we have done between the employer and the employee or the member,
right,
it is massive. And that's what's going to cause the revolution because people are
yeah,
getting to the point where they literally can't afford healthcare. And
yeah.
that's a problem. And we
Well, and
see it
by the
throughout.
same token, Larry, when you look at, and I've done a lot of research over the last couple of years and gotten intimate knowledge of, the payer mix that hospital systems, work with, and and employer groups disproportionately bear the brunt of the pain.
Of course.
They're paying, on a normal contract with any of the major bucas, large insurance companies. They're paying two and a half times what Medicare is paying that same provider for that same procedure. And no one, employers don't even know that they've been taking advantage to this level. Ever. I mean, no one talks about it.
Well, that's where I define it as the culprits in healthcare. And who are they? It's kind of an incestuous thing because you're completely correct. A small group employer they don't get their experience, right? Except in
Right.
Texas, where we forced a law. But generally, you don't get the individual experience. So you don't even know what your population is doing. What you hear about is pooling, and you hear about, overall book of business and all that. And so that's number one. Number two is you have no idea what the contracts are that are driving your cost and premium that they have with physicians and hospitals, whatever. And we all know I mean, we know because we're, in the insurance industry, the average PPO contract in 2024 was about 234% of Medicare.
Yeah.
The average PBM payment or cost was $134.87 PMPM. Think about those numbers.
Yeah,
They're insane. And
they're
then now look
insane.
and look at the mix now. So the insurance companies cannot pass on those kinds of costs to a 5,000 life case because the 5,000 life case has visibility into those costs and they have leverage. So who gets beaten up in that process? It's those cases between 50 and 500 lives. The ones that are fully insured, the ones, and maybe even it's 250. And I don't want to get sued for this, but I'm just going to say at one of the carriers I work with, we did a study. And what we found was that the profitability we had on small group versus on ASO was a 310% differential.
Wow, I'd never heard that before. That's amazing.
Yeah. So it's happening. And in a way, you can say, well, we need to blame the insurance companies. No, I think the insurance companies are at fault for sure because they're taking advantage wherever they can. But you have to really go back to what's the cost. And you can't have the cost of care be as high as it is. You just can't. No. The argument can be made, Larry, if we drop the cost of care, will the insurance companies behave and not just grab that as profit? That's where we got to make sure that that doesn't happen. But we have to drop the cost of care.
Well, it's really interesting. So I was having a conversation with a friend of mine who works at one of the bucas. And for the audience, we throw that term around buca. Buca generally stands for any of the blue, any of the Blue Cross Blue Shield networks, United Healthcare, Cigna, or Aetna. We use that term buca to sort of like put them all in a bucket. But I was talking to this person, and they were saying that and I hadn't even heard of it before until about 6 months ago. It's the California Office of Healthcare Affordability. And these folks are, I think, part of California Health and Human Services, and they have put in some new guardrails that are requiring health systems to limit their annual expense increase by really low single digits. We're looking like for the next year of 2026, I think the number is 4%.
It
And
is.
this particular buca, they said, well, we're all in. We want to support that activity because if we can keep the hospitals in check and not raising their cost structure, then we have a point to talk about. Interestingly enough, I found out a couple of weeks ago, the California Hospital Association is suing the California Office of Healthcare Affordability to eliminate that cap. Or I didn't read all the details, but to do away with that at least 4% for the first year.
You are completely correct. I'm intimately aware of it. And yes, they are suing them because they don't want that to happen. But, Vinny, I'm going to say this, and I hope it doesn't shock your audience, but the answer to this problem is not nibbling around at the edges like this. I applaud people for trying, and it's great. But, unless you got a whole bunch of piranhas that can literally strip it down to the carcass very quickly, this nibbling doesn't work. We have the answer right in front of us, and it's been there since 1963. And we have to take advantage. We have a national PPO, for gosh sake.
Yes, we do.
Let's use it.
Yes.
Medicare exists. It is there. It's a standard. Everybody prices to it and everybody can. And I'm not suggesting, let me say very quickly, that we go from 240% of Medicare down to 100% of Medicare because the hospitals are correct. They'd go bankrupt and we wouldn't be able to treat people. But what I am suggesting is, in 2024, we spent nearly $20 billion in PPO access fees. You want me to repeat that? Do you know how much money that is? It's ridiculous. let me add to it my second favorite. We spent $15 billion on direct consumer drug advertising. There are only two countries in the world that allow drug advertising, us and New Zealand. And you can't blame them because most of them are kind of a little bit drunk and they don't have big population. God bless them. I love
And they
them.
make it, they make a lovely Sauvignon Blanc. So
And they
yeah,
do make a great Sauvignon Blanc.
yes, they do.
So we shouldn't be doing that. You take just those two, you're talking nearly $40 billion
Yeah,
that is just being thrown away.
yeah,
And my point is, and when my book is finished, I will lay all this out. But the reality is, you can do a step down process to bring us closer to a program that allows for proper costs. And it's
yeah,
on both the physician and the hospital side. We can do both. And most people haven't paid attention to how well our physician groups have been moving their costs in the right direction. I mean, we in California today, Vinny, have some IPAs that are contracted at 120,
yeah,
110% of Medicare, which is fantastic.
right,
But
right.
find me a hospital system.
Well,
Um,
and this is you raise first of all, I couldn't agree with you more. I that's where my head has been for the last year in that general place. But going from, where we're at to that, I'll just say it out loud, Medicare for all as a solution, is something that, as you well know, is anathema to everybody in the industry that is even makes their money. The brokers would lose their minds. The the hospital systems would lose their minds. But if there was that, to your point, a step down approach that could make it palatable over a 10-year period or whatever the period is to make it happen, then I think we have something. I mean,
yep,
I cannot wait to be on Medicare in this next year. Right now, my premium that my wife's business pays for me to be on her plan is $1,100 a month for a
yep.
$14,000 deductible plan. Okay. I
I
can't
hear
wait to
you.
be on Medicare, and I'm not doing a Medicare Advantage plan either. I'm going straight
No,
in on
no.
traditional Medicare.
Take it from me. I've been on Medicare with a supplement, and I'm telling you, Vinny, it is the best experience I've had in my entire life. Now, I'm healthy, hallelujah, but you pay nothing. It's unbelievable.
Yep.
And your wife, my wife, I pay for her on ACA $1,175 a month for a
Yeah.
really trashy Blue Shield plan.
And
Sorry,
it's not even a plan. I mean, it's not even
it's
insurance. I mean,
it's
it's it's
not. It
it's
really
it's
isn't.
it really isn't. But I mean, I put up a quick post this morning on LinkedIn. It was just a quick explanation of what an annual out-of-pocket maximum is, because most people don't even know what that is.
Yeah,
Um, but I think what's interesting to me is, and this has been my take on sort of the LinkedIn ecosystem for a while now, and I really appreciate, you liking a lot of the things I post, and you commenting on my stuff, and I'm really thankful for you when you do that. Um, I feel like, you know, we've gotten to a point where there's a lot of really, really, really smart cooks in the kitchen. A lot
yeah,
smart people abound. I was having a little skin cancer removed from me the other day. You know, while I'm getting sliced and diced, I'm talking to the doctor. He's asking me questions about the insurance business, and you know, what my doctor knows? He knows how to cut out a skin cancer. He doesn't know any of the business related
no,
things pertaining to insurance. And you look at people, pundits, and all these other people who throw their information out on LinkedIn, they know their little slice of the pie. I like when people who have never been a broker start talking like they know what it's like to be a broker or whatever it is. And so you just said about, the potential of a Medicare for all solution is probably the most sane thing I've heard in a long time.
I'm sorry, I didn't hear your last comment.
I said that what you said about the Medicare for all solution was probably one of the most sane things I've heard in a long time.
And again, it doesn't have to be Medicare. You see, when I am working on a book, so let me just say that. And
Fair
if I
enough.
ever get it finished, it'll be very interesting because my book is going to be a little different than the ones that are out there. Everybody has a book about all the problems in healthcare. And no, don't get me wrong, we all need to be educated on the problems in healthcare. My book's primary focus is going to be a roadmap on how to fix it. I'm tired
Love
after
it.
46 years of people talking about how broke it is and nobody coming up with a comprehensive solution. Now, let me say quickly, when I publish it, I'm going to be hated. I'm probably going to have to hide somewhere. And it's going to
Well,
tell the
well,
truth.
I'm throwing my hat in the ring to help you. I mean, I'm happy to be a reviewer if you have any interest in me reviewing it for
I'm
you.
going to send you the manuscript when it's ready. Actually, I have 3 or 4 people that I value their opinions, and I will. But let me say this: I think the solution side of the fence is where we need to now start to focus because
Yeah.
I keep saying this. Everybody says national health care will never happen. American people will never put up with it. Well, you're right and you're wrong. If you get to the point where the cost of a private sector healthcare policy is more than what it would cost to have that payroll deduction out of your Medicare, if you will, payroll deduction, guess what? Americans are going to start paying attention because it's not more costly. And we can't make the old-fashioned argument about, oh, well, if you're on Medicare, you never get seen by a provider. That's crazy. Actually, private healthcare patients probably are at the back of the line in some cases. So that statement's not true. I am not an advocate for national healthcare. I think that is a mistake. And here's another fallacy people don't pay attention to. Those OECD nations that we compare ourselves to, here's a little fact most people don't pay attention to. They all have private and public health
Right.
care,
Right.
all of them. People say, oh, well, there's a national healthcare system in the UK. Yes, there is, but there is also a very thriving set of private practice work as
Yeah.
well. Same thing
Absolutely.
in Canada, same thing in Japan. Germany probably has one of the best private public mixes we've seen. So I'm in favor of us keeping
Yeah.
private and public. All I'm saying is let's make the adjustments to the private sector side so that we can stop, first of all, big cost shifting between Medicare and private sector. That's what hospitals do. And then between employers and the members, we got to stop that. I mean, I got in a discussion the other day, and you like this one, with somebody on a PBM, and they were talking about rebates versus non-rebates. And the first thing I said was, rebates are ridiculous. They should be outlawed. There's no reason for them in the first place, in my opinion. But even worse than that, here's a piece of rebates nobody pays attention to. So you're a big company, you sign up with one of the big three, and you get this wonderful rebate arrangement. Yeah, yippee do. And you're at 82% of AWP, which is, of course, a completely invented, valuation process by the big three. And at the end of the year, you get a massive check for $3.5 million. Yay. Is that fair, Vinny? How many companies get a rebate check and turn around and give back to the members
Right.
some of the money they spent
Correct.
during the year? Nobody. We look far and wide, and nobody's doing that. Which, of course, is why I love the fact that there's now a PBM out there doing immediate rebates, right?
Yeah.
At point
No,
of service.
absolutely. And Mark Cuban has begun to take up this conversation in the last couple of weeks about
Yes.
that very topic, and it's interesting to watch him wade into the game because now as he wades into the game and talks about rebates and talks about or lack thereof, and talks about fiduciary responsibility of organizations. I think fiduciary responsibility is something that we're only at the tip of the iceberg because, I feel like, you and I understand the behind the scenes stuff that goes on, and everybody else is just watching the movie, right? And there's so many moving parts and so many hands in the till, but I feel like there's so many areas, and if the fiduciary responsibility angle starts to take hold in corporate America, and employees start to rise up a little bit and start asking the right questions, then we might start to see a change in the conversation around all this.
I think you're right on target, and I'm paying attention to some of the big lawsuits that are out there now, Wells Fargo, et cetera. And the outcome of those is going to set a precedence that will then trickle down eventually into other employers.
Yeah.
But I also have to say this, and please don't be hurt by this. I think CAA also has to be brought to bear on the brokerage community. I'm just
Oh, dude, I'm
unfortunately,
all over that. I
yeah.
completely, I don't get me. That's a whole other episode, Larry. But
Yes, I agree. It could be.
honestly, that's a whole other episode. I mean, I take no umbrage to the to criticizing the brokerage community for their just general self-serving behavior. I mean, and I lived it, I saw it firsthand, and haven't even gotten warmed up to that topic yet.
Yeah, and I think, I think all of us have to recognize that no one party is responsible for where our healthcare system is today. I used to give a speech quite a while back in the early 2000s, and I talked about healthcare and said that visually, this is what healthcare looks like. Here are the five main constituents, and this is how they operate completely independent. And this is what healthcare should look like.
I agree.
And that is the challenge. The challenge is everybody is going to have to change to make this work. So I've been picking on hospitals and the price of healthcare, but employers are responsible.
Yep.
Members are responsible. People have to start taking responsibility for their personal health.
Yes.
They have to start taking responsibility for their behavior, and they need to build plans that are built that way. Brokers have to take responsibility for what they're doing and how they're advising their clients and where those clients
Yep.
are actually going and the success and outcomes they're having. And the government needs to be responsible. The government has to step up as well. They're responsible. So every constituent in the healthcare system I'm going to pick on in my book, and I'm going to pick on very vigorously.
Well, I would encourage you. So my inaugural podcast episode, actually technically episode number 2, was with a woman named Judith Kunish. She just wrote a book called The Center of the Star. And when you put your hand up with the 5 things, she basically talks about a 5-pointed star. And she comes out of the healthcare industry as she was a nurse. I think she might have worked for Aetna. She worked for one of the large insurers back east in Connecticut. And so she wrote this great book, and I think you should take a look at it, because
I
it's an
will.
interesting model. For me, it was 200 pages of a quick master's degree in what goes on in the healthcare system. She and I talked about. I jokingly said, "Well, it looks like the one thing you missed was the brokers, because the brokers weren't even mentioned." So she appreciated. We had a good talk about that. And so, no, I applaud that you're writing a book, and you may have to buy protection for yourself, but that'll be okay.
Well, it'll take some time because I'm still working, and as you know, I'm working on my passion project, and
Yep.
that now is being soft launched, and I'm hoping in its little way it's going to make an impact also in the healthcare
No,
space.
it's listen, you're one of the good ones. You know the industry, the ins and outs. I think that's important. So as we close, I always ask. I made an allusion to New Zealand Sauvignon Blancs, but I always ask my guests, first of all, whether you'll come back. I hope you will.
I will.
And number 2, what's your favorite wine? Do you have a favorite wine, a favorite region? Do you even drink wine? I'm just kind of curious, because I have my own little passion project, which is an Instagram called Vines with Vinny. So I'm always interested in people's take on the wine, on the wine world.
We are wine lovers for sure. California, in my opinion, has changed the world on the wine front. Um, I tend to be, I started out very much a cab guy, and I still am. I still love a robust, wonderful Cabernet. But over the years, I think I've become intrigued by a lot of the blends that are there. And one of my favorite wines today is actually out of Paso Robles, a winery called La Venture. Um, there's a little French mafia revolution going on in Paso Robles, if you're unaware of it.
Well, I'm aware.
And yeah, and they are producing some magnificent wines.
What was the name of the winery?
La Venture
La
is,
Venture. Okay.
yeah, they actually were the first winery in Paso Robles to get a 100-point rating from Wine Spectator.
Oh, oh,
He built a lovely wine called For Her. I don't think you can get your hands on it anymore, but it was magnificent. But he has just a plethora of wonderful wines. And what's happened is a lot of Frenchmen have followed him now into Paso Robles, and there are probably five, maybe six wineries there now that I would put up against anything in Napa.
no. I agree with you. Between Paso Robles and the Santa Rita Hills for Pinot
Yes,
Noir. I mean, come on. I mean, the production going on in the Central Coast area is from Paso Robles south is
it's
nothing
amazing.
nothing short of remarkable. I mean, it's
It
really
is.
high class stuff. It's great.
And food
So
is following as it always does. They have now, can you believe Paso Robles now has three and soon to be four Michelin star restaurants?
wow.
Paso Robles 10 years ago was a McDonald's town.
Well, my wife and I were on vacation in Sicily last year. We actually ran into George Dow just
And
after he
yeah,
sold his winery for $1 billion. They're doing
yeah,
okay in Paso Robles. So,
yeah. A
well,
dear friend
Larry, I
of
want
mine
to
is
thank
down the
you.
hill from
Yeah.
here and bought 250 acres. And he and I have known each other a long time. He wasn't in the wine business, and he's now dedicated 75 acres because Dow is above him, and they loved his soil and said, if you put it in, we'll buy every single grape that you can produce. And so now he's in the wine business, even though all he was doing was drinking wine.
Well, listen, Larry, I think we covered a lot of interesting topics
We have.
today. There's thousands of interesting more topics we can cover. Keep me abreast on the book. I'm happy to help you give me some feedback on that as it develops. And I just want to thank you for being here today.
Thank you for having me. Always great to talk to you, Vinny. I appreciate it.
This podcast reflects the personal views of the host and guests, not their employers or sponsors. See you next time.